Good to see you again.
Okay,
Okay, Junyoung Lee, please.
Yeah, I'll start. Hello, I'm Junyoung Ri from Severance Hospital, South Korea. Today I present a case of incessant tachycardia that caused heart failure in young patient. The patient was 18-year-old male without any medical history. He felt dyspnea since few years ago, and it's aggravated and 3 days ago. 3 days before going to hospital, and initial case showed tachycardia. And echocardiography showed a global hypokinesia with an ejection fraction of 30%. And the patient was referred to our hospital. This was the EKG taken in our hospital. It showed narrow QRS tachycardia with heart rate of 153. So in this confusing EKG, this look like conducted sinus beat. And this look like not conducted P wave. So it could be evidence of AV dissociation. And this part in looks like a VT with 2 to 1 VA conduction. QRS morphology of VT is very similar with that of sinus beat. So this case showed a VT with capture beat and occasional VA conduction. Several cases were taken before the procedure. Tachycardia was incessant and the pattern was similar, and you can see the another APC from another origin. After taking carvedilol, heart rate decreased a little bit, but VT was ongoing. This is the chest X-ray. You can see the cardiomegaly. Okay. This echocardiography was taken just before the procedure, and during ongoing tachycardia, it showed several severe global hypokinesia with ejection fraction of 18%. So we start the APS. This is the initial catheter positioning. We use the HIS RV catheter at HIS and RV. And lumen decapolar catheter was placed at CS, and micro catheter was inserted through it to AIV. And we use the HC grade catheter for 3D mapping. At start, it's a sinus rhythm. Cycle length was 672, and AEH was 71, and HV was 445, and QRS duration was 86. And during sinus rhythm, RV pacing with 360 resulting 2 to 1 VA conduction. But in RV pacing 310, it looks like VA dissociation with just occasional VA conduction. And tachycardia was easily induced by isoproteinerol. And during the tachycardia, cycle length kept changing. HV interval was 51 millisecond, which is similar with the sinus rhythm. And during this cycle length wobbling, HH interval preceded the RR interval. And we start to make activation map at RV, but there was no earlier signal than his during the tachycardia. We also mapped the LV and aortic cassette, and also his signal was the earliest. And we can see that activation sequence is proximal his to distal his, and then V. This is the activation map during tachycardia of LV, and delta. We can see that tachycardia started from the focal origin, that is around the proximal His area. And this is the propagation map. So in summary, this was incessant tachycardia causing heart failure. Wave conduction was weak, and cycle length was wobbling. And during this wobbling, HH interval preceded the RR interval. And during activation mapping, there was no earlier signal than proximal His. So in conclusion, this is a Parisian ventricular tachycardia, and the origin is very close to His. So plan was ablation of proximal His area and CRT implantation. We started ablation at LV anteroseptum because activation map suggests the left side was started earlier. But there was not successful. So ablation catheter was placed at LV anteroseptum and started ablation at right side proximal His area. During ablation, RBBB developed, and after more ablation, tachycardia terminates with complete AV block. This is the 12-read EKG after ablation. It shows the complete AV block with the escape beat RB pattern. And this is the final ablation site. After ablation, we implanted LVB CLTT. This is the EKG after CLT implantation. And LV ejection fraction improved to 30% after CLT implantation. So I prepared a brief video about the case report, similar with this our case. So in this case report published on 2023, the patient was a 65-year-old man, and EKG showed LVBB type wide course tachycardia, and it's almost identical to sinus rhythm. During EPS, his signal was earliest as our case. And HV time, HV interval was same in sinus rhythm and in VT. RV patient showed VA dissociation. So in this case, they tried to avoid AV block first. So RF ablation was delivered slightly distal to his region. VT stopped quickly, but UVT recurs soon. So they stopped ablation, prescribed antiarrhythmics. But medical therapy failed to manage VT. So 2 months later, they did a second procedure, but second procedure also failed. So they started amiodarone and implanted ICD. Third procedure was done after ICD shock, and in this time they ablated his bundle. It resulted in complete AV block and no further VT occurred. As our case, they treated this type of VT by ablating his bundle. So this is the end of my presentation. Thank you for your attention.
Thank you so much, Dr. Lee, for the very nice case. You presented very well, and it's very interesting, and it's pretty rare also. This I never see that one. But can you go back to the ECG, please? Yeah, I have one question. So it look like at first, how can you differentiate this narrow complex tachycardia from between SVT and VT in this case? So it also probably that the patient also has a junctional tachycardia, a bit sinus. I'm not sure, but can you explain? Can you tell me how can you differentiate between VT and junctional tachycardia in these patients? Please.
Actually, I thought that there might be a transient tachycardia, but the reason why we call it the VT is you can see the capture bit, and maybe I'm not that sure though. Maybe there's some different QRS morphology that show the fusion bit. So, because of AV dissociation, I think that.
Okay, thank you. And how about during the procedure? May I know why you decide to put the microcatheter to map for these patients? Do you think it's come from the submit area or the around the outflow tract area? Because the morphology doesn't look like that it's come from the outflow tract area, right? So may I know why did you decide to use the microcatheter in these patients?
So this procedure is not done by me. I'm fellow. So may I
Okay.
ask the operator? Is it here? I would like to answer the first question. Let's see. Yeah, we can see the different QRS morphology. I think the different QRS morphology may be a fusion bit or capture bit. So that's why this must be VT. And second question, probably this tachycardia is originate from the close to conduction system. So I would like to map may I may have might have a chance to map septal branch cardiac vein. So just in case, I use the microcatheter.
Thank you so much, Professor Ong. Nice to meet you.
Nice to meet you. You have any comment, Dr. Park? Go ahead. No? Okay. Why? Let me answer your question, Hank, best way I can. How many
Yeah.
QRS morphology do you see in surface ECG? Tell me.
Multiple morphology.
Multiples, how many, man? Gotta be more specific than that. I'm asking you.
1, 2, 3, 4.
4. And then which
Yeah.
one you think that the capture the sinus beat? That's the next question I have.
So like the force complex.
Number 4 complex. After that,
Yeah.
how about numbers 8? Is it a capture beat?
Keep coming. That one.
Yeah, it's also the sinus rhythm.
All right. You
Mr.
think it
B.
is, huh? You think, right? This guy,
Yeah.
this guy, and then here and there. So that complex has a what? PR interval, and then QRS is what? Lead 3, slightly RS, notching, right? So
Yeah.
those are sinus captured beat, let's assume. This is a different beat. This is a complete, this is no P wave, nothing, very narrow, okay? Axis, what happened? Axis changes it completely.
Yeah.
Therefore, very unlikely junction rhythm. Understood?
Yeah.
Okay, so that's why this is VT. If there was a preceding sign of P wave, something, you could argue that there could be aberrance, but there's no aberrance here. So this is very narrow looking, narrow complex ventricular tachycardia. And then what's the mechanism looks like? RR interval, very all over the place. There's no fixed coupling anywhere, exception of capture beats. That means most likely
It's automaticity or trigger mechanism.
Focal automatic tachycardia mechanism favored for it. We don't have a diagnosis yet. Okay, let's go to intracardiac signal. Oh, just go back to chest X-ray for me. What is that thing in the center? That's a watch or something you're showing? What is this? Device? Oh, telemetry patch. Okay. Okay, that answered that. And then can you go back one more time to chest X-ray? There's some calcification. That's also patch. Right underneath there. That's a lead. Okay. All right. So cardiomegaly, we agree. Let's go down. Okay, echo, we've seen that. Okay. Go down. Okay, you look at your catheter placement now. You have a multi-electrode catheter placed in the septum and the coronary sinus. And look at where the distal RV catheter is. Okay? Infero, basal, like almost apical midway down. Okay? Now, you keep that in mind. And it is clearly the septum, right? Agree? It's like look at the LA view. It's septum, okay? Right here. Septum. Okay, go to intracardiac signal. So what do you see here? Baseline. Now, this is an RV display. Is it 1, 2, 3, 4 is a distal tip you're displaying? That is my question. Which electrode displaying? Very distal RV catheter? Yes or no? Yes?
Yes.
Okay. You will see very interesting potential. Right bundle, right there. You see at the beginning? I want you to pay attention to that and his bundle up there. Okay? Go to tachycardia now. Be pacing. It's okay. Tachycardia. Okay. Let's watch this carefully now. Unfortunately, this one did not have a his bundle. Maybe questionable his bundle. But first 3 had a his bundle. Okay? This is could be sinus rhythm. Okay? But I don't see clear-cut his. The subsync tachycardia, there's something in the front. Look at the right bundle potential. The earlier. You see this? This bit here. If that is a his bundle right there, this is a right bundle. Almost same time. What did they tell you? You can go to the next slide. I think you can see even better. Some of them look very, very good. Go next slide. Right here. Okay. Now you see better. So you have a his bundle conduction here during the tachycardia. Okay. This is the tachycardia bit. No P wave anywhere. His conduction is proximal to distal clear, but also RV. Almost same time as a distal his. This favor for what? Let me ask you this question now. Right side or left side? Tachycardia, focus on talking.
The right side.
Right side septum. So perhaps for the mapping strategy standpoint, when you see this, you may want to manipulate that multi-electrode catheter, try to place along the right bundle. That's why you're using multi-electrode catheter. No other reason. You don't stick the multi-catheter for no reason, right? So you could pull it out a little bit, and then you may record all the right bundle, right catheter, ventricular septum catheter. Try to see where is the earliest potential breakthrough, right? even though it's coming top to bottom, you don't know. Maybe there is I think your catheter was sitting close to mother vent junction. That's what I'm thinking, looking at it right now. Therefore, there's possibly any early site to that, then that his bundle or difference was a timing difference. That will give you a clue where to map first. I think that's an important clue. Because our lap bundle recording would be ideal. If we do this case, really try to avoid the heart block, I would put two catheters, one in the right side septum, another in the left posterior left bundle crystal catheter, and compare. This is where the tachycardia coming from. That would be very elegant study. I know you did map right left septum beautifully, but I think that would give you better idea. Okay. Okay. Go to the next slide. Okay, look at this potential here now. I want you to pay attention to this. This positive, right? Was a negative sinus. It's a sinus beat. Negative, become positive. So impulse clearly coming from top to bottom. Here was a negative, became positive. So that happened what? The timing almost same. And this is negative, right? Was a positive. So somewhere this between, you're breaking through. But the question is why the mother band is even early, almost same as the distal hits. So this is something that I think we should be answering during the mapping. Okay. You can see last sinus beat, very beautiful his bundle potential activation, and the right bundle is early here, even sinus. So I think either this patient have a conduction system issue, tachycardia, or that most likely you could maybe map the first easier way to map the right septum and figure out whether this tachycardia breakthrough. But I don't know whether we should be, oblating right up front his bundle or any AV block business. Obviously, you do it best you can. Second thing I want to point out for the 3D mapping purpose. Next time when you see parahis and DT, you need to create the two map. One is local myocardial conduction map. Exclude the his bundle if you can. Okay, you have to manipulate digitally by manually. So this is a clear-cut BTV. You see P wave summation here, right? So then you cannot take that point. This would be best bit to take. So you're going to create only local ventricular activation map first. Second one, you're going to only take his bundle and right bundle. Okay? So you're creating two different maps because you have to select the window of selection of tachycardia. So you do that for right and left side both. The Japanese paper that you mentioned, they did not do that. That is the confusion there about. So you should map two separate maps, like a SCAR VT, the same way, except that a little more work. But it would be much more elegant to look at the conduction activation and local myocardial activation. Then you have a much better clue next time. Okay? Maybe it could avoid the heart block, this patient. Could be. But the QRS morphology nature, when you see it, this bit here, very close to sinus rhythm. Okay? So question is that this is a junctional rhythm, and this is a typical VT beat, or this is a mixed tachycardia, junctional tachycardia, other VT form. Show other tracing. Okay, for example, this is a catheter-induced PVC, okay? This is not count. But this bit here, I have a question about it, because QRS is slightly different, not quite same. You see? AVR, take a look at it, become positive, biphasic. So if this is a truly VT beat, then your right side is earlier, like here, than that his bundle that you record. So I think would it be a strategic standpoint view? I think you try to do your best you can, but then we want to create a two different map, put together, and then figure out where they're coming from. I think it's an elegant study. And then I think mapping catheter selections and everything, I think is perfect.
So this EGM is very interesting. Good morning, Dr. Han. This is Hipa. And we know the junctional rhythm, even though it is very narrow QRS and very similar vector to the sinus QRS, but the QRS morphology is a little different to the normal sinus QRS, right? And so I always have a curiosity, why is it different? And as Dr. Huang mentioned, his bundle polarity changed. In other words, this rhythm coming from very close to his bundle, but coming to the his bundle in another direction,
Right.
and break out to the, although it coming through the conduction system. Yeah, look at this the electron comparing to the sinus conductive torus and the junction of the BT. Look at the HD grid map. The polarity and width and everything is different. So there, even though it is very close to the his bundle, actual conduction pattern is different. So Dr. Hong show me solve my long-lasting question. It's very interesting.
Yeah. Interesting by Professor Pang.
And you think what are these potential? What are these potential? This is here, but now. No shock potential. Yeah.
That's so I don't know whether they're mapping left side. That's a left side. Dr. Park.
Is it left side map?
That's mapping, yeah. So it's septal. The septal fascicle.
Okay.
That's why I don't think we don't need heart block this patient, probably. So I think if you created the one reference catheter, long crystal catheter, left to right ventricle septal side, record the bulk conduction system, and then I think you map with a very elegant study.
Then how do you decide the oblique point? Left, right, or
Left to right?
transaortic
No.
or transeptal?
I think we do left side probably transeptally, okay? Because you don't want to touch the reference catheter. And then right side, obviously, use a deflectable sheet to go. But then question that we have still answered that where is the tachycardia focus? Because if you look at his bundle, this bit here, this is a tachycardia most likely pronounced. Look at the far field early here, you see? And then local later, second, double potential. There's no A here, okay? So this is all V. This far field V would give you a clue, and this in the his, somewhere in the high septum, 7 and 8, okay? There was a HV here. So this is, I thought that this was a complex, but there's no A here. So this is V fusion here, AV fusion, early sinus rhythm, but then only V here. So that EKG a little bit different EGM without his. And then I think his is right underneath there. You see the proximal? There's some notching there. So it's going to be, agree with you, it's probably parahisian, but the question is how high parahisian is. But the QRS is wider here, right bundle. So I think probably left side parahisian, possibly, but we cannot 100% be sure. You have to really tell you detail. Yeah. There's a case report like this being oblate from the left coronary cuspid as well. Okay, so it's something that you think about that because they're very close to conduction system. Sometimes they're approachable to the coronary cuspid aorta.
So in other words, because of this potential, probably the location of target site. And at that time, there's no his potential.
Right.
That's why you told if we can, we may try to avoid the heart block
Yeah.
from left side.
Maybe you can create a heart, left bundle branch block, maybe, or maybe first VAB block. But I think if you can get rid of, get away from a heart block, every cost would be better for this young man. Yeah, even though especially he has an ejection fraction, low ejection fraction.
So best way to find out all is to conduction system potential, but know his potential.
Know his potential. Okay. And then you should create a separate conduction map to avoid, because 3D mapping system automatically will tag a DVDT to the highest window signal. So that big, huge potential going to interfere with your window. So we have to adjust it very, very carefully. And then you only tag those spikes. That way, I think would be compared to anatomic site. Okay?
I think this is the key slide of today's presentation.
Yeah, it is. And then you can see, if you take a look at this PVC from the right bundle, this is a left bundle morphology, okay? PVC from the IV distal catheter. Look at what happened. That potential is still there, same, almost. So the timing, so it's coming back up. So clearly, it's not a right bundle side, but it's a septal side, and the probably higher up, probably some sort of upper septal fascicular source, very close to his bundle.
Okay, so I would like to ask to Dr. Taewoong Kim. Taewoong Kim, are you there?
Yes.
So after ablating the parahishian VT and generating heart block, so the CRTD is appropriate approach. I think this is patient with very severe heart failure. But how do you think about the conduction system pacing or left LOT pacing, LOT CRT pacing?
Yeah, I think the CSP will be the good option for this kind of patient because this patient have intact distal conduction system and have narrow QRS. So yeah, ECG shows LVB pacing, right?
Yeah.
Yeah,
It is.
so I think
Well
it's
done.
very good candidate, and we can make very narrow and beautiful QRS in this patient. So it will be the best option in this patient.
But most of our CSP data was from mid-range heart failure or just the AV block and the normal LV function. So in this kind of a very severe LV dysfunction, is it appropriate to put the CSP?
Yeah, of course, we have a lot of data in BCRT, but recently some RCTs are ongoing and already published it and shows very reasonable and comparable results compared to BCRT. And this patient, even though this patient have very severely depressed elbow ejection fraction, maybe yeah, tachycardia may have huge contribution to heart failure. So, and as I already mentioned, the distal conduction system intact. So, I think CSP will be the better option in this kind of patient.
Could you tell us a little more about the level of block, left bundle branch block level, and what is the appropriate site of CSP?
Yeah, we have also many option regarding CSP and also his bundle pacing and left bundle branch truncal pacing and left fascicular pacing. And I think all result very comparable. And his bundle pacing is, I think it is not appropriate in this patient because we already made block in distal his area, so his bundle pacing will is not that appropriate, and I think the left bundle branch pacing will be the best option, but vascular pacing will be comparable as a QRS duration or heart failure improvement.
진행을 해주시죠.
Okay, any other comment or question?
Not comment for you. Thank you for your kind comment. Now, anyone else has any comment? Any question from anybody else from international team? Nothing comes up there. I think if there's anything, any question we see in the screen? No, no one ask any question.
채팅창 nobody.
Nobody. Okay.
So what is your future plan, Dr. Medical therapy and CLT. This is young man.
I'm continue to perform heart failure management with the GDMT. He is improving, and so I would like to follow up him with a GDMT for heart failure.
So basically, tachycardia cardiomyopathy is a predominant diagnosis patient.
How's the chamber size? It reduced?
Yeah, a little bit reduced. However, I performed the BT ablation just 1 month ago, so I need to
wait.
watch out.
Yes. Probably at least 3 months follow up, then we should know some answer.
I wonder you check the cardiac MRI. This patient.
We have no chance to perform cardiac MRI because
Emergency.
BP was incessant and ongoing.
I see.
His blood pressure is very low, so I didn't have any time to wait for
Is
cardiac MRI.
this device is MRI compatible?
Yes.
Okay. Then, I mean, excluding the area that you ablated, you should see other area reasonably well because you electrode place in septum, right? So MRI not going to have too much interference, I think.
In addition, after VT ablation, I performed the temporary pacing. However, at that time, he was in shock.
Oh, I see.
Just pacing induced more pacing induced cardiomyopathy, but the could not be tolerable for him. So at first I implanted. I have a plan to implant CRT 1 day after ablation. However, he couldn't wait. He couldn't tolerate. So I implant CRT LVB pacing emergently.
So actually, the companion trial is a very old study, but the sub-analysis companion trial shows the baseline RBBB heart failure patients actually CLTD worsened the clinical outcome. But the opposite side, if you try to CSP, if this kind of severe LV dysfunction patient has septal fibrosis and the septal LG enhancement, probably it also make a trouble for long term. So it's very tricky to make a decision, CLTP or CLTD or the CSP.
Do you have a dual chamber temporary pacing unit in the hospital? Double channel? Like a pulse-up we use?
We have device generator, but we don't use that quite often. But the cardiovascular surgeons use it.
Sometimes you have a, if you do EP study, you have a CS catheter, just leave a CS catheter in, you pace AB sequentially. Sometimes help a little bit, if you really cannot really implant the device, whatever the reason, infection, whatever it might be. So somebody have a low ejection fraction, AB synchron is very important, okay? So then you can leave a temporary wire into the one to the CS, another one into the RB septum, and then pace. That's sometimes helpful, okay?
I guess the most probable cause of heart failure is tachycardiomyopathy.
Yeah, I think it is.
Patient, but because the patient is still young, so after watching the ejection fraction recovery, if it is not complete, you need to study more about the
fact that this is but it's fact that the patient has an automatic tachycardia, that alone already favor for the tachycardia-induced cardiomyopathy. If you had an underlying substrate, you're going to have a reentrant VT somewhere. So I think a mechanism of tachycardia presentation pattern of EKG is very important in terms of prognostic assessment. So those patients, you should be able to very aggressively get rid of the tachycardia, because that's the one benefit most. So it's the right thing to do. Okay. Thank you for everybody. Thanks for coming. Have a good weekend. See you again.
Thank you so much.
Thank you.
감사합니다.
아이, 정말.